Good morning, everyone. We are really excited to have Kevin Yao from Toronto talk to us on GLP-1 RAs. Dr. Yao is a nephrologist who's just finished his training. He did most of his training at UFT, except for internal medicine at Western. After finishing his GEN fellowship, as well as a cardio-renal endocrinology metabolic disease fellowship, which is sort of what I guess he's talking about today. He did a master's in Clin Epi at UFT, and he's finishing off a GN fellowship and will be joining on staff at UHN as a clinician scientist in the coming months. Welcome, Kevin.
Thanks so much for the kind introduction and invitation to talk. So today I'll be talking about, what's increasingly talked about even sort of in the popular press, GLP-1 receptor agonists and the gift that keeps on giving. And so my disclosure is not related to the talk. And really I'm going to talk about the different clinical effects of GLP-1 receptor agonists and talk about some of the latest evidence for use in chronic kidney disease. It's a pretty rapidly evolving field. It's hard for even me to keep up sometimes. So I'll just be talking about some of the newest studies in the area. And I'll start with a case. We can come back to it at the end and talk about it. But this would be kind of a typical patient you might see in clinic or in GN clinic. So Miss GN, a 62-year-old lady with FSGS, biopsied a while back, thought to be obesity related, but at one point the proteinuria went up quite high, and she was treated with prednisone, and it didn't really help. And she had adverse effects from the prednisone, which might be expected because she had obesity at baseline. And she also has hypertension, dyslipidemia, obstructive sleep apnea, and she has a history of a TIA. Her BMI is in the obese category. Blood pressure is not bad. And she's already on a background of SGLT2, candesartan, and she's on statin and aspirin. Her GFR is sort of, moderately advanced CKD. Her ACR is 242. She has 2.8 grams of protein a day, and she has a normal serum albumin, but she's not diabetic, mildly hyperkalemic, and her cholesterol is not quite at target. So obviously this is a certain kind of talk, so you could tell I might be hinting at something, but what could potentially be beneficial for her. So we can come back to this later and talk about some of the evidence. So GLP-1 receptor agonists, I'm sure everyone on the call's heard of these, and it's often in the popular press even these days. So in 2023, it's declared the breakthrough of the year by Science magazine. There's even sort of a CNN special on Is Ozempic Right for You? And for the nephrology community, the FDA approved Ozempic recently for diabetic kidney disease. So patients are actually often the ones sometimes bringing up this class of medication themselves. So GLP belongs to the class of agents called incretins. That includes GLP and also GIP. I showed the anglerfish there because GLP, the pro-glucagon mRNA, actually comes from the anglerfish, and that's where it was first discovered. But the incretin effect really refers to the fact that in patients with type 2 diabetes, this incretin effect is reduced, which is the normal insulin response that increases in response to an oral glucose load. And so when it was recognized that that effect is diminished in patients with diabetes, that sort of led to the therapeutic development of incretin agents, DPP-4 inhibitors, which we're quite familiar with. GLP couldn't be used initially because it was so rapidly degraded. It has a half-life of 1 to 2 minutes. But after some modifications, now we have longer acting versions that we can use clinically. So most people here have been using DPP-4 inhibitors for such a long time. They work quite well for glycemic control with pretty few adverse effects and don't have eGFR adjustments. GLPs are essentially quite similar. They just, instead of DPP-4 breaking down the incretins, GLP-1, you just give back the GLP, and it just has such a more potent effect, and that's why there may be just stronger effects giving back the GLP as opposed to DPP-4, and that may explain some of the differences between the classes of medications. But beyond just glucose control, it's increasingly recognized that these just have so many effects on different organ systems because of the effects on cardiovascular. events from previous glucose agents. They were explored in CVOTs, and they do have benefits on the vasculature, the heart, and of course, we're going to talk about the kidney today. DPP-4 inhibitors and GLP-1 receptor agonists both actually induce a little bit of natriuresis, not a lot, but a little bit. But a really prominent effect is, decreasing albuminuria. Probably the most popular effect that patients are asking about is for weight loss, which is mediated by central effects to increase satiety and decrease your intake of food. And then there's also gastric emptying. There's some tachyphylaxis to that phenomenon. So it's probably not the major way by which people lose weight, but it also happens. And then there's a lot of literature coming out now about effects in fatty liver disease. In terms of the different GLP-1 agents, there's quite a few that have been developed now. There's sort of the shorter acting incretin mimetics, and then there's the humanized GLP-1 analogs. Probably the one that most people are familiar with, the one that most people in Ontario use, is semaglutide. But dulaglutide and liraglutide also have good evidence for them, and liraglutide is also used in some people in Ontario. There is an oral form of semaglutide available now. It took a long time to develop, just because it's even this new form, which is sort of formulated to maintain the pH and to improve absorption. It only has about 1% bioavailability, but it actually is covered. But there's not as much evidence for it, so it's not very commonly prescribed yet. Although some new evidence is coming out about the oral class of a semaglutide. They do work pretty well as diabetic agents. So, for example, you can see semaglutide often lowers your A1C more than 1%. And so it's quite an effective agent for glucose control. But obviously, the most common reason that people are excited about it is the weight loss. This is liraglutide. The most striking aspect of this class of medications is that, if you see here in the gray, once you stop the medication, you really start to regain the weight. And unfortunately, actually in the study, you just go even above where you started. So sometimes it's a little bit difficult to convince people to try to stick with the medication for life, but it really is kind of needed as an ongoing therapy for the weight loss aspect, at least. People are exploring a lot of different doses of GLP-1 receptor agonists. So for semaglutide, the dose for diabetes is 1 milligram, but for weight loss, the approved dose is 2.4 milligrams. But people have been exploring very high doses. So this is a recent study that looked at up to 16 milligrams a day of semaglutide. And what they found is that you do get a little bit, like 0.3% more lowering in A1C, but you get a little bit more weight loss, but it does come with a lot more side effects. And so they sort of conclude that maybe the incremental benefit of the super high doses isn't worth it. So there may be a limit to kind of how high you can go with these medications. And obviously tolerability is a big thing for staying on them. As I mentioned, there's been evidence for cardiovascular benefits. There have actually been quite a number of cardiovascular outcome trials now. They're all a little bit different. They use different agents. They have different durations and slightly different outcomes. But overall, in meta-analyses, they do show a benefit on cardiovascular events, or MACE. And something interesting is that unlike SGLT2 inhibitors, there does seem to be some signal for stroke reduction with GLP-1 receptor agonists, which is slightly different. And there's also a benefit for heart failure that's been observed, although there's some differences trial to trial, as I mentioned. Kidney outcomes kind of seem to always take a second seat in these cardiovascular outcome trials to cardiovascular events, but they have explored them, which kind of led to further studies. And what they did find is in these cardiovascular outcomes trials is that when they looked at a composite renal outcome, it did show a protective effect with the GLP-1 receptor agonist. This is shown here as the leader trial. But these were mostly low-risk patients. They're not generally patients with advanced kidney disease or a lot of albuminuria at baseline. But the outcome was mostly driven by a reduction in new macroalbuminuria and not what we call hard kidney endpoints like the double of serum creatinine or dialysis. There's very few dialysis events. And so that kind of led to the need for a kidney-specific trial. So how about DPP-4 inhibitors? So we've been using them forever, but not for lack of trying. They've actually sort of just come up negative in terms of benefit on kidney outcomes. Linagliptin, as you can see there, in exploratory analyses, it does reduce albuminuria a bit, but overall, fairly large outcome studies have just shown a neutral effect, both on kidney and cardiovascular outcomes. So in comes the FLOW trial. Likely everyone here has heard of the FLOW trial, but this was a kidney specific trial designed with a kidney endpoint in mind. And it was came out in 2024. And in the study of about 3,500 patients, patients were randomized to semaglutide or placebo. They were all on a background of RAS as best as tolerated. And you can see there's certain GFR limits and albuminuria limits for the inclusion criteria. And the primary endpoint is a kidney endpoint. So kidney replacement therapy, eGFR below 15 for 4 weeks, and a 50% reduction in eGFR. They also have renal death and cardiovascular death in there. And then they have some secondary endpoints. If you kind of look at the baseline characteristics, the interesting thing is it is quite a cohort who generally has obesity. So, the average BMI is 32 in the trial. So the average person in this trial is obese, and the average GFR was 47, and quite a few of the patients have macroalbuminuria. Just because of how long ago the trial was actually designed, SGLT2 inhibitors weren't very popular at that time. So there's only about 15% use of SGLT2 inhibitors in the FLOW trial, even though it came out quite recently. But most patients were on RAS blockade. As many people also heard, this trial was actually stopped early for efficacy. And so it showed benefit on the primary kidney disease endpoint that's shown here, hazard ratio of 0.76. And that includes both the kidney aspect and the cardiovascular aspect. And then when they sort of separately look at the kidney-specific component, that also shows benefit with a hazard ratio of 0.79. When they also look separately at the cardiovascular outcomes, there is a reduction as well in death from cardiovascular causes and the first major cardiovascular event. And something that's often looked at as a secondary endpoint in large trials now for nephrology is eGFR slope. Something interesting is that you can see there's a little dip in the eGFR when you start with the semaglutide. That's actually seen in most of the GLP studies. It's thought that maybe it could reflect weight change. There's a little bit of natriuresis as well, so that could explain it. It's not as prominent as the SGLT2 inhibitors, so it seems to be a relatively small dip, and it kind of reverses if you stop the medication. But the overall difference in the FLOW trial for GFR slope annually is 1.16. Some of the previous studies have generally said that if you have a GFR slope difference of 0.75 per year, that's likely with a really high chance of being clinically important. So that's quite a reasonable difference in eGFR slope that was seen over the course of the study. There were subgroup analyses, and this particular one raised some questions for some people. You always have to take these subgroup analyses with a grain of salt, but there was not a lot of SGLT2 inhibitor use, but you can see that those using SGLT2 inhibitors, it's kind of a wide confidence interval. So it raised some questions about the additive benefit. They have subsequent publications that show that there isn't a difference between SGLT2 inhibitor use, but people still debate it. So the FLOW trial really solidified GLP-1 receptor agonists as another pillar of therapy in diabetic kidney disease, joining RAS, SGLT2, and non-steroidal MRAs like finerenone. At the same time, actually in Ontario, we have been exploring how much GLP is used, and in kind of a broader population. Of course, the FLOW trial is a clinical trial, so it's a bit more restrictive in who's included in terms of GFR. So people below an eGFR of 25, for example, would have been excluded. So we actually did a study where we looked at GLP-1 use compared to DPP-4 use in Ontario. It's mostly semaglutide that's used. And then we used propensity scores to kind of compare the groups. And the idea of this study was to actually look at cardiovascular outcomes in a kind of a wide range of patients with kidney disease. So we looked at major adverse cardiovascular events, including cardiovascular death, non-fatal MI or stroke, and PCI or CABG. In terms of our Ontario cohort, there's about 24,000 GLP-1 receptor agonist users, some representation from stage 4 and stage 5 CKD, sort of a handful of dialysis and transplant patients as well. Not a high burden of sort of coronary artery disease or MI or heart failure at baseline. But something interesting in sort of like more contemporary usage is that in a real world setting, probably RAS blockade of 68% is actually kind of pretty good, actually, for real world. And then this being a more recent study, SGLT2 inhibitor use is about 40%. So not bad. And the degree of albuminuria is a bit less than in the other, in the FLOW trial. In terms of who's actually giving out these medications, so this is a couple of years ago, but it's not nephrology. It's mostly general practitioners, endo, and internal medicine make up the large proportion of the prescriptions, although maybe it'll change in the future. You can see as you get to more advanced CKD, sometimes it is nephrologists prescribing it, and perhaps it'll have changed in more recent years. So what did we find? We did find that, so these are the curves for the composite outcome. Red is GLP, blue is DPP4. And it did show a benefit on MACE. And then we explored, which of those outcomes in that composite are contributing. And it seems to be largely cardiovascular death that's contributing, because you can see that it actually separates quite early on that there's a reduction in cardiovascular death. When we look at some of the other outcomes like MI, stroke, or unstable angina, they're all not significant, actually, although some of the point estimates favor it. Same with coronary vascularization, kind of right on the dot, neutral. So it really seemed to be mostly cardiovascular death driving it. We looked at heart failure, and we did see a benefit with heart failure as well. And all-cause mortality, also we saw a benefit. And something that's not looked at a lot in trials is peripheral vascular disease revascularization. There also seemed to be some benefit on peripheral vascular disease, which is probably quite important for diabetic patients who are at risk for amputation. And we also did subgroup analyses, and similarly, we didn't find any differences by kind of stage of CKD, albuminuria, or SGLT2 inhibitor use, although some of the confidence intervals are wide just because of smaller numbers in some of the groups. So how does this compare to the FLOW trial? Pretty comparable overall. So basically, our study in the FLOW trial shows that MACE is reduced with a significant reduction in cardiovascular death, neutral effects on MI, stroke, and then both showed a reduction in all-cause mortality and heart failure. We showed this reduction in peripheral vascular disease revascularization, probably because we had a lot more events and a larger sample size. The FLOW trial, it kind of suggests it, but it's about 3,500 patients, so they may not have had enough events to show a difference. So overall, kind of this just expands to a wider population. The finding of heart failure is kind of important, and there are also dedicated heart failure trials looking at improvements in HFpEF. So there's a couple of them that have been done now, 2 with semaglutide, 1 with tirzepatide, the STEP HFpEF and SUMMIT. And they generally have shown a benefit on this Kansas City cardiomyopathy questionnaire, which is often what they've chosen as their outcome, which is sort of a functional sort of status kind of measure that's validated for heart failure. And they do show a benefit on this questionnaire. Just for reference, they show a difference generally of around 7 on this questionnaire versus other medications like SGLT2, ARNI, Spirono. They've only shown smaller benefits like 0.5 to 2.3. So it's considered a substantial benefit in heart failure as well. We actually just wondered, since this class of medications is so great, how about just like all-cause ER visits and hospitalizations? So we did a little bit more statistical modeling just to look at all-cause ER visits and hospitalizations with GLP-1 receptor agonists. And we actually did see that there is a bit of a reduction in the hospital visits and ER visits. Didn't seem to be specifically from any cause, but just an interesting finding, just more and more benefit from this class of medications. So now we'll turn a little bit to the non-diabetic side. It's pretty well established that there's a close link between obesity and chronic kidney disease. Not everyone with obesity develops CKD, But some people with obesity can get, FSGS, and they can have hyperfiltration. There's thought to be RAS activation, and there's some speculation about adipose tissue compressing the kidney itself. So multiple mechanisms by which affects the kidney. So there's been interest in exploring a GLP-1 receptor agonist in patients who are overweight or obese, who have albuminuria, to see if there's benefit. So another study that is a bit smaller that you may or may not have heard about is the SMART trial. It also came out at ASN last year. It's a smaller, kind of more mechanistic trial. The idea is to see if semaglutide reduces albuminuria in obese, overweight people who don't have diabetes. And just something to note is that unlike the FLOW trial where they're using 1 milligram, here they're using 2.4, which is the weight loss dose. And they have a run-in phase where they optimize RAS blockade and SGLT2 inhibitor use. So as I said, it's kind of a smaller study, about 100 patients, but they kind of have an interesting mix of some GN patients, hypertensive patients, some obesity-related glomerulopathy patients. So more mixed etiologies of their background kidney disease. And kind of impressively, they did show quite a reduction in albuminuria, about a 52% reduction versus placebo. And they kind of had this escalating dose scheme. They have a washout phase where the albuminuria goes up a little bit after you stop it. I do have to say that as a secondary endpoint in this study, they do look at GFR, like measured GFR with iahexol and cystatin, and they didn't see a significant difference on that. Although you just have to keep in mind that this is a relatively smaller study, 100 patients, so it's not necessarily powered to find an eGFR difference, but definitely a big reduction in albuminuria. There's also another study called the SELECT trial that also gives us some insight into effects on non-diabetic people. So this is a very big study, kind of a cardiovascular size trial with 17,000 patients who are overweight and obese and 45 or older, and they have to be not diabetic but have had prior cardiovascular disease. About 20% had CKD. Just something interesting is that like a quarter stopped the medication prematurely. But what I've shown here is that they actually had some secondary analyses for kidney endpoints. And in this non-diabetic cohort of sort of overweight or obese people, they also see a benefit on composite kidney endpoints. What does that make up of? So it's kind of a 5 category endpoint. So death from kidney disease, of which there were 0, but also dialysis, eGFR less than 15, 50% reduction in GFR, and onset of macroalbuminuria. You can see it's probably largely driven again here by the reduction in macroalbuminuria, but generally, favorable. Again, they look at eGFR slope in this study, and do keep in mind that this is, again, not specifically a CKD population, so it might not be as impressive, and they also report it by 2 years, whereas you should kind of be thinking about eGFR slope on an annual basis. So the total eGFR slope per year is actually 0.39 difference of benefit. So it's not as much as the 0.75 that's reported to be the amount that's supposed to be beneficial. But if you do look at those with an eGFR below 60, it's 2.19. So it does suggest that there are benefits on eGFR slope in patients with CKD who don't have diabetes. So it's overall supportive evidence, although it would be kind of nice to have a dedicated trial in non-diabetic patients. Everyone always asks, how does this class of medication work? How is it exerting the kidney benefit? And it's not really well established. It's likely multifactorial. Obviously, this class of medication has an effect on cardiovascular risk factors. You get weight loss, which likely helps with the proteinuria. The glycemic control improves, which also likely helps. The LDL will go down a bit. Blood pressure goes down about 2 points. People have done some sort of mediation analyses, and those don't fully explain probably what's going on. So what people have kind of postulated is that maybe there's reduced renal hypoxia or anti-inflammatory effects, but still not very well established. It's kind of like it works, but we don't exactly know why it's having an effect on the kidney. GLP is actually expressed in the kidney. It's mostly in the vascular smooth muscle cells and the tubulointerstitium, but it's not clear that the benefit that we're seeing is sort of a direct effect in the kidney. So people aren't sure about that yet. It doesn't seem to be the tubuloglomerular feedback that we see with SGLT2 inhibitors. There is sort of a sister study to the flow trial called Remodel that has been going on, and hopefully we'll know the results maybe in the near future. But it was a smaller study with about 100 patients again that had a very similar population and protocol to flow, but these patients underwent a kidney biopsy and MRI at baseline, and then they do it at 1 year as well. The idea of this study is to just glean more information on how GLP-1 works in patients with CKD. And so they're using bold MRI functional imaging to ask if this renal hypoxia or reductions in renal hypoxia explains the benefit we're seeing. So perhaps it'll lead to more insight. There's some smaller studies that have come out. There's a lot of variability in the measurements here. So there's a lot of noise with these kind of measurements, and it's a little bit finicky, but hopefully it'll lead to more insight into how the medication actually works in the kidney. In terms of how low eGFR you can use these medications in, for liraglutide and semaglutide, they're thought to be acceptable down to an eGFR of 15. Below that, they're said to be contraindicated. And so if you look at the monograph, it'll say that semaglutide and tirzepatide are not recommended for end-stage kidney disease because of limited experience. As I showed, there's maybe about 200 patients who are in Ontario who are using GLP-1, but it might be a population that actually benefits from this medication. People on dialysis are at extremely high cardiovascular risk, as everyone knows. For young people in particular, their cardiovascular risk is 500 to 1,000 times that of sort of their healthy age-matched peers. So they really could stand to benefit. And there's some patients we know that they could be eligible for a transplant, but their weight just prohibits them from being considered eligible, and it could increase their eligibility as well. And obviously, diabetes is one of the most common causes of end-stage kidney disease. And unlike other medications that we can't use because of renal elimination, GLP-1 receptor agonists are not eliminated by the kidney. So it's not a pharmacokinetic reason not to use it in this population. So we, based on kind of that observational work, we designed a trial called GUARD-1, GLP-1 receptor agonist in patients receiving maintenance dialysis. So this is a CIHR-funded trial that is going to look at GLP-1 in the end-stage kidney disease population. We're just kind of getting all the paperwork like pushed through Health Canada, but we'd be delighted if Ottawa participated. But essentially in this study, we're going to include adults with diabetes and end-stage kidney disease on stable maintenance dialysis and randomize people to GLP versus usual care. And then we'll titrate their dose. We will be a little flexible with the dose titration just because we are concerned that maybe dialysis patients may not tolerate the medication as well. And so we may be more generous with the usual 4 and 8 weeks. And this is a feasibility trial to see if a larger trial is feasible. So we're going to follow patients for 26 weeks. And we're aiming to see how well we can do with recruitment, aiming for 40% of eligible people participating and getting an idea of how adherent patients would be to the medication as well, and the ability to follow up on medications. I see a comment in the chat about if we're collecting weight, we are going to plan to collect weight. And there's another comment about the ORN, trying to get the ORN to get behind their use on transplant eligibility, but they want to see more data. There actually is also a separate trial that's going on called OK Transplant 2, led by Kristen Clemens, that's looking at GLP and a multi-component dietary intervention to improve transplant eligibility. So it's kind of a similar study in some ways that's also looking at that question. So as I mentioned, this is a feasibility trial. So the primary outcomes are mostly feasibility criteria. But we're also going to collect sort of secondary outcomes such as weight, blood pressure, glycemic control, insulin dose. Some people kind of postulate that patients don't feel hungry when they get GLP and their phosphate control becomes amazing. So we're going to look at that as well. And we're also going to collect information on quality of life. Adverse events in this population will be important, particularly nausea, GI side effects that might prohibit sort of long-term use. So we're excited to get this trial underway. As was brought, I see another question about worsening sarcopenia. That's always a concern. You don't want maybe a person with a BMI. You might think twice about enrolling someone with a BMI of like 18 in the study. Some people have concerns about, you definitely do lose some muscle if you lose weight. There are newer studies looking at addressing sarcopenia with sort of different monoclonal antibodies and different other agents in addition to GLP. So some of them look at like myostatin inhibitors plus GLP to see if they can prevent the weight loss. So it's an interesting question that comes up, and people do have real concerns. If you give a frail dialysis patient a GLP, are you going to do more harm than good for them? So kidney transplant recipients, so many reasons it could be beneficial in this population. Patients commonly develop diabetes after transplant as well. They get a lot of prednisone, and they may have had diabetes before as well. But there's not a lot of data in this population, but there was one study that came out relatively recently that's actually relatively large. It included almost 2,000 patients in the US with type 2 diabetes who were receiving a GLP-1 receptor agonist. They did a couple different analyses, but they actually did find that there seemed to be a lower risk for graft loss and actually mortality in both sort of adjusted and unadjusted analyses. And so it's supportive of potentially use in the transplant population as well. There's also some trials that are getting underway to explore use of GLP-1 in kidney transplant recipients as well that are occurring. But GLP-1 alone is, not the only story. There is actually so much that seems to be going on in this field. And so there's all these dual and poly-agonists. Probably everyone here has heard of tirzepatide, which is the one that's approved. But there's also GLP-1 with amylin agonist, and then there's triple agonists with GLP, GIP, and glucagon. And then there's a couple other ones as well. As I said, the most, common one, or one that has the most data to date, is tirzepatide or Mounjaro, which is a dual GLP GIP agonist. It actually probably has a bit more GIP effect, and it's thought to have a little bit less GI side effects, possibly because of that imbalanced effect on GIP, and perhaps it could be more tolerable. And definitely it has a more potent effect on weight loss. The question that comes up is tirzepatide going to sort of replace semaglutide in the future? We don't have that data yet, but we're always kind of gleaning insight from non-kidney specific trials. So in SURPASS-4, which is another sort of cardiovascular and insulin dosing trial, tirzepatide was compared to insulin glargine, and they do see a benefit on eGFR slope in this trial as well with tirzepatide treatment. But we don't have a lot of data on specific use for CKD and kidney endpoints yet, but more to come on that probably in the future, since it's an evolving field. Another agent that's under examination is cagrilintide. And so it's an amylin analog. Amylin probably has sort of, in combination with GLP, is sort of thought to synergize, increase leptin sensitivity, and have more effects on glucagon secretion. And it's definitely been shown to potentially cause more weight loss. And so the speculation is maybe that will improve glucose control more, and maybe it'll have beneficial effects on kidney endpoints as well. So there's a trial called CAG-SEMA that's going on right now. It's actually completed enrollment, but the trial's ongoing. And it's kind of has 4 arms to it. It's looking at cagrilintide alone, semaglutide alone, placebo, and then the combination. And the idea is to see if adding in the cagrilintide will reduce the albuminuria more. So basically exploring whether this has more effects on reduction in albuminuria. And so it's not a very long trial either. It's about 26 weeks. So probably, in the next maybe 1 to 2 years, we'll know an answer to this. And retatrutide is a triple agonist that sort of gained some excitement among the many agents, but the reason it's gained a lot of excitement is it causes sort of a lot of weight loss, up to 24% in some of the earlier trials. It's a triple agonist, so GLP, GIP, and glucagon. And there is a trial called Triumph Outcomes that is going on. It's, again, a cardiology-sized trial, but it actually does include a kidney-specific endpoint. So it's comparing retatrutide to placebo and kind of has a bit of a mixed population that they're looking at. People age 45 with a BMI greater than 27, with or without diabetes. And they either have to have established cardiovascular disease or CKD. And so their primary outcome includes both MACE and both a kidney outcome. And it's a fairly big trial, and it's 5 years in duration. So it's going to be a little bit of time before we know the answer on this one. But all that to say that there's really a lot going on in this area, and that the landscape might evolve. We might move on from semaglutide to using other agents in the future. So a lot more to come. So if we come back to our case that we were talking about before, it's essentially, a 62-year-old female with FSGS, doesn't have diabetes, but has significant proteinuria, and, sort of a moderately impaired GFR. GLP-1 could be considered in her, and based on sort of the SMART trial, some of the data from the SELECT trial, it probably would reduce her albuminuria further. We don't have hard data on that. And off-label, in clinic, if we can get it covered for a patient, we might consider using it. The practical aspect right now is that it's not covered for non-diabetic patients in general, unless they have great insurance, but it might be something that might be beneficial in this population in the future. So hopefully more info, but some people might already consider prescribing it for her. And we have done it sometimes for some of these patients who have quite a bit of residual proteinuria and might still be at risk. So GLP-1 receptor agonists have a lot of established indications already. So obesity, diabetes, sleep apnea, cardiovascular disease, metabolic liver disease, diabetic kidney disease, and even osteoarthritis. But there's all these other indications that are under exploration in the future. Peripheral artery disease, we saw a benefit in our trial, but there's a specific trial that's looking at that to look at sort of exercise capacity and to see if it actually has a specific benefit in a focused trial on peripheral arterial disease. And hopefully we'll have more info on the future on non-diabetic kidney disease in the future. So I'll end the talk there. In summary, basically, GLP-1 receptor agonists have many different benefits: glycemic control, weight loss, benefits on atherosclerotic cardiovascular disease. The FLOW trial demonstrated a large benefit on diabetic kidney disease, and it's really a pillar of therapy now. But some of these other more recent studies also show potential benefit in non-diabetic kidney disease, particularly for people who are overweight and who are obese. And there's a lot of different studies going on looking at it in a broader population, some including our own, looking at end-stage kidney disease and also kidney transplant recipients. And then there's a lot of these dual poly-agonists that are under evaluation that will likely change things in the future. So I'll end there and acknowledge Ron Wald and David Cherney, who have been kind of key for some of the work that I've shown here. And I'll open it up for discussion and questions.
Excellent. Thank you, Kevin, for that really nice overview. And if others have questions, please put that in the chat or raise your hand, and you can unmute yourself. Greg.
Thanks, Rob. Thanks, Kevin. That was a great talk. I guess I'm more interested in the dose. So the FLOW trial was 1 milligram, and all these other trials are still using the conventional higher dose. And there's lots of anecdotes even on microdosing, even going much lower, like 0.5, 0.25. And are there any trials that are going to start looking at these? Because to me, it makes sense to start going lower. My own personal experience is there's a lot of side effects. The patients I see are transplant patients that happen to get on it by their endocrinologist. A lot of side effects at the higher dose. And if you can start to show some efficacy at these lower doses, that makes way more sense to me. I'm sure the drug companies aren't interested in that, but investigators might be. And what's the dose you were using? Sorry, I didn't catch it in your pilot trial that you're doing too.
Yeah, that's a great point. Tolerability is an issue, and I guess the problem right now is that we can't really predict who's going to have adverse effects. It's a little bit, some people seem just fine, and then other people, the lowest dose, like 0.25, they have like significant issues. And some of the patients are really smart now. They know about this micro dosing. Essentially, they count the clicks on the pen, and it's like, we tell them to go up by like 3 clicks a day until they can tolerate it. And if they do that, it often does work better. Um, you know, definitely for the weight loss component, the higher the dose, the more weight you lose. It's not entirely clear though. There's not a lot of data on if you don't achieve the highest dose, like is your kidney benefit lost. So we often go to the highest tolerated dose. So in our own study, we're planning to have it kind of like the flow trial, like up to 1 milligram a day. We're not going to like the 2.4, for example, because we're not thinking that it's a great idea to try in dialysis patients to go up to 2.4 a day.
You mean a week? Sorry, Kevin. Yeah. You mean per week, not per day?
Per week. Sorry, per week. Yes,
okay.
Per week. But yes, sometimes that slow up titration helps, but there are certain patients who just can't seem to tolerate it no matter what you do. And we did have one patient who was tried on it, and they, technically they're not supposed to be associated with AKI, but they just had such bad, volume depletion that they actually got admitted to hospital and had to start dialysis. So there are some rare instances where that happens, but yeah.
So you don't see any trials being initiated at even lower doses like 0.5 and seeing for efficacy?
Yeah, I haven't seen any of these trials. I think they're mostly focused on they seem more focused on their newer agents currently than looking at the lower doses of the current agent. So I haven't seen a lower dose trial that's underway.
Thanks.
Excellent. And for the GUARD trial, we are mostly going to be looking at people who would be eligible to get GLP-1 RAs in Ontario anyways, right? So we are mostly looking at people who are more than 65 who would have coverage from ODB
Yes.
to get GLP-1 RAs.
Yeah, that's correct. Yeah. Most people on dialysis kind of do have drug coverage. So is the fortunate thing, but we're mostly looking for people who have coverage.
Yeah. I mean, it's really, as a comment, it's really nice to see that, we are seeing studies in advanced CKD and dialysis happen so quickly. I think for statins, it took 2 or 3 decades for the dialysis trials to happen after they were available for the general population. So it's really nice to see that. For your, the propensity score, the ICS data, I guess, has that been published or is that under
revision? Yeah.
The revision. Okay. That'll be really good to see. I guess Peter is coming on. If you have a question, just unmute yourself. Yeah.
Yeah. Hi. How much of all these benefits on kidney and cardiovascular outcomes relate to weight loss? Because if that's the case, I mean, I've had some people lose a bunch of weight on 0.25 or 0.5, others who lose none on higher dose. If it is all correlate with weight loss, maybe we should be titrating dose to that.
Yeah, that's a good question. So some of the benefit, you could speculate that maybe some of the benefit in albuminuria might relate to the weight loss. There was this trial with albaglutide, which is not used anymore. I believe it's off the market and no longer sold, but it didn't cause a lot of weight loss, but it still showed a cardiovascular benefit. So based on that trial, there's thought that perhaps some of the benefits on cardiovascular effects are independent of weight loss. So it may not all be necessarily weight related. The issue is that it's still not very established exactly how the cardiovascular benefit is mediated. But that study, because of that finding, suggested that maybe it's not just weight loss.
Yeah, it would be nice to know how much relates to that. As a follow-on, you mentioned, and I sort of only vaguely noticed in the past, that blood pressure reductions aren't much, which is sort of surprising because at least old literature said dietary weight loss led to substantial drop in blood pressure. I think if you lost 10 kilos, your blood pressure went down by 5 or something in a couple of intervention trials. Again, it'd be interesting to know if blood pressure, and anecdotally, I've seen all sorts of people who are start to faint after they lost 10 or 15 kilograms and you have to cut back on their drugs.
Yeah, I think in the flow trial, like the blood pressure reduction's only about 2 points or so. So it's not particularly impressive, but it could definitely vary from individual.
Just since you're an Ontario expert, tell me, does ODB cover higher doses of semaglutide for diabetes? If A1C or weight hasn't come down enough, can you prescribe 2
They only
milligrams?
cover 1 milligram, so they only cover the 1 milligram dose. We have the occasional person that the drug rep, like we give them 2 ones to make a 2. And so, but we just give it to them for those who we think really might benefit. But that's totally not a like fully coverage thing.
Thank you.
Thank you. Todd. Dr. Fairhead, if you're on. I think he's unmuted, but I cannot hear him.
Yes, I just see the hand.
Yeah. Maybe put your question in the chat if your mic's not working, Todd. He may have a GN question because, your case, is there any trial apart from the SMART data, which was in, non-diabetic with proteinuria? Is there any, which I guess might be a bunch of IgA and something else there, right? Is there any GN specific trial that is going on?
I believe they're trying to see if there is interest from industry in doing sort of the equivalent non-diabetic trial. And so I believe it may be in the works, but nothing is confirmed. Nothing is confirmed yet. But it would be, very helpful to know.
Yeah, exactly. Yeah, great.
Well, maybe my colleagues know this answer. I've never prescribed one of these, so I only see my patients that come in on them. But if we are starting to prescribe them, do we have to care about their other insulin and oral hypoglycemic agents? And do we have to worry about hypoglycemia, or we just prescribe it? And
that's a good question. Usually if they're on insulin, it's kind of like this conversation happened when SGLT2 inhibitors do, and who should prescribe it, and should you collaborate with endo? Usually if they're on insulin, I think it's good to talk to their endocrinologist, because sometimes they seem to lower their units of insulin a little bit, like maybe up to 10% sometimes. But technically on their own, they're not really supposed to cause hypoglycemia. And generally, the literature suggests that they don't really cause prominent hypoglycemia, but the only time people do get hypoglycemia is if they're on concomitant insulin.
So that's the only time you would adjust, if they were on insulin?
Yeah, if they were on insulin. Otherwise, we do, I guess a kind of a mistake sometimes it's made is that some people are already on a DPP-4 inhibitor. We generally stop that. They're often switched from one to the other. It's not like harmful to have both, but it's kind of just probably just not necessary to be on both.
Thanks.
Yeah. But also sometimes if people have huge weight loss, like, Peter's point about the blood pressure, we do see, again, this is not firsthand, right? I've seen other people started, and with weight loss, you need to reduce their diabetes medications. And if they don't have an endo, then a lot of fear, again, you're absolutely right. This is similar to the Flozin fears, right? When it's an unfamiliar drug to us, we think about it as a diabetes drug, and we are not comfortable taking over diabetes care, which, if you're prescribing it, it feels like you're taking that over, especially if they have diabetes. Is that a real fear, or it's just something that we are afraid of because we are unfamiliar with this drug class?
Yeah, I think it probably depends on personal experience. I think if you've never prescribed it before, there was a number of considerations and things to monitor. So it probably depends on comfort. Because now that it's, approved for diabetic kidney disease, if you're looking after a diabetic patient and they're not on it, would it be helpful for you to start it and kind of like get the inertia going? It might be helpful, but you also have to the other things we usually do is, it's a bit theoretical, but we usually send them for an eye exam first for a theoretical concern about worsening diabetic retinopathy, especially if their glycemic control is poor. And then we always ask about like the history of like thyroid cancer, medullary thyroid cancer. And then the other thing that we usually ask about is, prior history of pancreatitis. There's a theoretical concern about pancreatitis. So there are a number of things to think about, or contraindications to like think through before giving it, for sure. So definitely requires a little bit of comfort, and if it's the first time prescribing, it can take some time to be comfortable with doing that.
Yeah, for sure. I think it's a little bit trickier, especially with the injectable, right? Like in endo, they have, nurse educators, and I think it would be useful to have pharmacy or some other additional help. But one way to think about it, I guess it's similar to RNS, that arbipoetin or whatever. When we start in the kidney clinic, there is some nursing education that goes on. So maybe we have to work on that aspect. Conference room.
Hi, it's Todd. Sorry, I was having trouble connecting before. I had a question more about access to medication, and I'm not sure if you have any insight here, but as you mentioned, it is funded under general benefits for patients who are diabetic. Is there, I've struggled to get access for patients that I think would benefit. If they have private insurance, for example, and they're not diabetic but obese, the private insurance companies, often their criteria are much greater than what the trials actually had. And, I think that there is benefit, in obese patients for heart failure and so on, and yet there's no indication for that. Do you know if there's a push to present some of this to Ontario Health because of the hard outcome data, so that we can expand prescribing indication? And I guess the second part of that is, how many more years until semaglutide is on generic and off patent?
Yeah, great questions. And I don't know the exact answer to the question. There's, in fact, the insurance companies are trying the opposite, is that some of them were previously funding semaglutide, and some of our patients have received letters saying that they are no longer funding it because of like excessive costs. There is the very rare patient who has excellent insurance, where you say that they're obese, and then they get coverage and they don't have diabetes, but that's like the exception. I find the only time where I found that patients, where sometimes insurance companies fall for the trick, is they see they're on an SGLT2 inhibitor and they think they have diabetes, and they don't have diabetes. They just have CKD, and then they approve it. But the other thing is, in terms of going generic, not imminently. The thing with these medications is it's actually the injector has a lot of patents on it. I think each GLP-1 receptor agonist, there's like 8 or 9 patents at least on the injector. And so it's actually not imminently going generic. So that's why they've actually not gone generic for longer than other medications. And there's an article, I believe, in JAMA that talks about the patents on those injectors, and it's almost a sneaky way to extend the patent life. But unfortunately, I think there have been efforts in the US to lower the costs, but it's still unaffordable for most patients to pay out of pocket for it. We have the occasional person who's very motivated, and we have some very motivated patients who are like, they go to like the pharmacies, and they know that if they get the 1 milligram pen, that they can get 4 more doses of 0.25 out of the 1 milligram pen and make it last longer. But so far, no news on when it would be covered for non-diabetic patients.
Yeah, and that's going to be a big hurdle. You're exactly right about those patents. There was a lot of hope riding on the oral versions. I think there are some others also in development, orforglipron or stuff like that, and maybe some of them might come to generic faster, perhaps, because they won't have the injectable patents.
Yes. So Rybelsus is also approved, actually. There's a LU code for Rybelsus, but it doesn't have the evidence for it. So we don't, the one patient I gave it to, we accidentally gave him expired samples and he got really angry, he threw them out. So I've never actually prescribed it to anyone, but technically there's an LU code, it just doesn't have the evidence. The evidence for the oral is actually with these higher doses than are approved in Ontario. So it's like 3, 7, 14 milligrams are approved in Ontario, but there was a trial called the SOUL trial that showed cardiovascular benefits with higher doses. So kind of the approved dose for the oral is not technically necessarily cardiovascular dosing. So we haven't really used it. My understanding is they're trying to, apply for indications with the oral medications in the future. So it may change in the future, but to date, actually, the oral hasn't really taken off yet, but it could change in the future. As you said, there's that other there's the other oral agent that's also kind of under evaluation, and so it could change in the future.
Yeah, as you showed, there is there are many more trials going on. So this is a very, very exciting field, and we hope GUARD and OK Transplant, I guess.
It's all OK Transplant, yes.
OK Transplant, yeah, they are successful in the pilot feasibility and will hopefully get the evidence to use it more broadly in the next few years. So thanks again for that wonderful overview of the topic, and good luck on the trials.
Thank you so much. Thanks, everyone.